Oh, I just pushed it out.
Here?
Mine mainly is
I know that's gonna go underneath.
Sorry guys, it's my first time with camera. It's all good.
Not that way. I didn't know how I was gonna respond to that one. It's not going down on these.
All right, guys, we are moving on. Are we ready? Yes. Next section. So we're going to be discussing tibia and femur joint tests. But before we get into that, I kind of want to do a quick little recap of the anatomy of the lower leg. So Lee's already taken you through the anatomy of like the tibia and fibula, but we're going to be working with the femur. So we're going to talk about a little bit of that anatomy. So femur is your thigh bone, obviously. Okay. So we are working with the distal part. What does distal mean again?
It's
Farthest away. So we're working the farthest point. On your femur, in the back, you see these knobs right here? These are called condyles. Let me just get his leg up. That's beautiful. Okay, so
Arthur's amazing.
I know. Hey.
I just didn't have some issues.
So these are called condyles. Condyles of the femur. So if we bring him around, when that leg's there, you're on either side of the knee. Those are condyles. Your tibia also has condyles. So you have condyle. Tibia has condyles as well. In between the condyles of the tibia and femur, that's where your meniscus would sit. So these are, just want to give you that update of what your condyles were. We're going to be using a towel. So everybody has a little rolled up, nice tight towel on their table, and this is what we're going to be using to do these tests. So I'm just going to kind of walk you through this, and then we'll do some demos. So tibia and femur joint tests. We're doing the anterior posterior glide test of the tibia and the femur. So we are, in this one, we're gliding the tibia while we're stabilizing the femur. Did I say gliding? Yeah, that's what I want to do. All right, our first, so we're supine, leg is straight on the table. We have our little baby leg here. We're standing at the side of the leg, hands over hands, as possible to the joint line. Now, when we are working with the joint line, when we say hand over hand, so we've got femur here, tibia here, okay? So we're not, when we work to the joint line of the tibia fibula is like right up underneath here. Again, the same thing, we're not gonna be putting a lot of pressure on the head of the fibula because that's sensitive. So this is going to be as close to our joint line that we're going to be. When we're on the femur and we're working, we'll be putting our towel under the condyles of the femur. Again, you want to be as close. We don't want to be directly in that popliteal fossa. We don't want to be in the bend of the knee. We want to be right up underneath where those condyles are because we're going to be supporting, this towel is going to be supporting the femur at one point, and then we're going to use the towel to support the lower leg, the tibia and the fibula. So that's going to be our supporting. Okay. So our first action, we're stabilizing the femur with the towel. So you will see that we will put the towel underneath, at close to that joint line, underneath the condyles. And when I get the person on the table, I'll show you better that here's the towel and here's where their condyles are. We're going to do a little test. So this is going to be kind of almost like a little rebound test that we're going to do. Our result, if you can glide the tibia posterior and there is no rebound, there's a posterior lesion. So as we have that towel underneath and our hand over hand, we're just going to be just doing a little rebound, okay? So we've done that. What did we do the rebound on? We haven't yet. Rebound test. Rebound. First time. Yes. Yeah. Okay, rebound test, we're going to be utilizing that throughout this. We'll use it on, obviously today, you'll utilize a rebound test on the sacrum. Where else do we rebound?
Everything.
Everything, all the things.
So I was like, what? Yes.
All the things.
All the things.
Okay.
Checking for mobilization, so you're going to do it everywhere.
Yes. So, it'll make more sense when I get it. So, femur, the towel under the femur for stabilization. Okay, then I've got my hand right up underneath. So we have tibial tuberosity here. I'm hand over hand. Okay, and I'm just doing a little rebound. Okay, I'm just pushing down a little bit. And I'm seeing, is there movement? If the movement, what's the first one say? If you can glide the posterior tibia, so as I push down, if that tibia goes down, Oh, there you go. Posterior tibia, but there is no rebound, there's a possible lesion. Meaning that when I push down, if it goes down but it does not come back up, right? So I push and it's like, oh, it goes down, but you don't feel that spring come back up. That's telling us right there that there's a posterior lesion. Meaning there is something that's going on back here in the back. Because I can push down and it stayed, but it won't spring back up. Does that make sense?
Does
So it's like
everybody understand that concept? 'Cause
Yes.
it's a concept
Big
we
one.
come
Yes.
in a lot.
lesion, push down, it sticks, it's because there's your boo-boo.
You always name the lesion for the way that it will go.
Posterior.
Yes.
Not the way that it can't go. Because it
The way
can't
that
come
it will
back
Yeah,
up.
it goes down, correct.
So what would you call that, the downward lesion?
Posterior
Posterior
lesion.
Okay,
Yeah.
okay.
Posterior lesion.
Yeah, and that's what you like, oh, and you'll just note that in your head, like,
So the way
okay,
it goes.
posterior lesion. Now the
Yes.
opposite of that,
Right, then it goes.
right? So we do the same thing, we're doing that. Now, when we go to do that rebound, if there is no movement, like, again, I rebound and it just sticks, that is an anterior lesion because now that it's up on top, right? So here's our problem area, we can't even get to the posterior because it's right up there on the anterior. So, push down, goes down, doesn't come back up, we know that there's something going on posteriorly, correct? We push, there's no movement, Anterior.
Exactly.
Great.
Nice.
Oh, next part, feeling the bone itself. So again, as we're doing the rebound, you also want to sense what does that tibia feel like? Well, the bone itself, is it hard, right? Is it hard? I mean, just like cement. So if there's tension, if the tibia is more rigid, there's an ascending lesion, meaning there's something that's going up towards the top. Ascending towards the top. So we have a lesion that's somewhere heading up. If the femur is more rigid, which we'll get to that, so again, we get to femur. If the femur is more rigid, then there is a descending lesion. Descending, coming down. Now, isn't there a possibility that sometimes they can go both ways as well?
Yes,
Let me make sure.
yes. We had some of you already feeling the bone, not everybody, but we palpated how the bone felt. So you're gonna be taking that in when you do this. Like, how does that bone feel?
You're looking for bone tone.
Bone tone, bone tone, it's our new thing.
It's our new.
Is that a new shirt?
It's a new shirt. Yeah.
Might get some interested clients there.
Hashtag.
Maybe not. I digress.
We all do.
We right there with you. Right there with you.
That is why you're here.
Yeah.
All right, so now we are going to, so that's tibia on the femur. Now we're going to the work, so all of our work's been done on the tibia. Now our work is going to get done on the femur. So we're doing the same thing, but we're taking the towel now. So instead of under the condyles of the femur, our towel is going to be under the condyles of the tibia. Right there, okay? And our hand is going to be on the femur. Now we're not going to be on the kneecap. We want to be above the kneecap. Okay, we're still hand over hand, again, as close to that joint line. So above that kneecap, hand over hand, and you're doing that same rebound test. It's just that little push down. And we're seeing if there's any little spring to this.
Mike is showing you that it's rebounding like this, but
But it doesn't.
but you're actually putting some pressure in to get it to come out. You know what I mean? You're just not
Yeah,
getting
it's
that on
tight.
top of the bone. You're actually putting some pressure in to get it to go down, and you're coming off to kind of give it a spring, but it's not quick like that.
Bouncy.
Yeah.
So when you release, you're releasing slowly or
No.
just the same way you press down?
You're releasing a little more quickly to try to get it to come up.
Okay.
So yeah, so your compression, and when we demo, we'll take it through. But yeah, your compression will be slower, and then it's just like releasing your hand to see if there's that movement that follows it. So work on the femur. We're stabilizing the tibia with the towel. Stabilizing the tibia with the towel. Our hand over hand. So as we are pressing the femur posteriorly, I can't even read, it's light. Okay, same thing. If there is no movement and it won't come back up, then we have something wrong where?
Posterior.
Posterior.
That's right.
Okay. Posterior of what bone though? The femur, exactly. So we have something posterior in the femur if we've pressed and it's not coming back up. Same thing, if you can glide the femur, if we can't even get the femur to go down, I know, I keep doing that, it's like I'm doing CPR. If I'm pressing that, it's going down, and we can't get any movement whatsoever, then where's my lesion pattern?
Anterior.
It's anterior. So it's the exact same thing that we did with the tibia, it's just the same work that we're doing on the femur. And then again, if the tibia is more rigid, we're gonna be feeling that again within our assessments. Yes? Sorry, say again?
What about, like, people with hurt knees or injured knees or?
Contraindications.
Contraindication. of the
Yes.
knee. What do we-
So there are contraindications, and we'll get to, as we go through them. Yep, take our next part.
That would be a knee replacement.
Yeah.
Yes. ACL injuries, any instability within, so I would just think ACL injuries, PCL injuries, any, I mean, we're not doing any, I'd say any injury
If you're bone
within
on bone, you know,
fractures.
yep.
Most of you.
Yeah. Well, and no, not necessarily. So it says ligamentous instability. When you have somebody who has had an ACL injury, an MCL, PCL, all of the CLs, lateral, medial, any of that, if they have had a tear, it's something very visible. So if there is some instability, when you do any sort of little movement with them, I mean, there's a test that orthos do and everything, that when you do that, that whole tibia can come forward. So I mean, you will see somebody who has instability. And a lot of times if it's that major of an instability, I mean, even when they're walking. And so, I mean, you're probably not gonna be doing anything that, oh, well, you test this, because if there is that much instability, they're probably seeing
And
surgery.
they'll tell you on your history taking,
Right.
hello.
Yes.
On your history taking, they'll tell you, I've torn my this, I've had a repair
ACL
of my that.
replacement,
And
yeah.
so you are pretty much gonna shy away from movement things like this with those kind of responses.
What about fractures? Is there a time for healing or anything? I mean,
Yes.
because I shattered my femur 22
Oh,
years ago.
yeah, no problem.
No, yeah.
What is that,
We're good.
12 weeks? 16
16.
For femurs, you mean?
for fractures?
Yeah,
Six.
I like to go when the doctor says it's healed, is when I.
Well, and, I mean,
I'm on
to-
that page, you know?
Yeah, and if
20
somebody,
years is no problem, though, no.
I didn't
If
think,
it's not healed by now, you're in
well, that was
trouble.
my question, is how long do you let it heal?
Oh, yeah, well, 12 to 16 weeks, something like that. You know, they say, they usually tell you 6 weeks, but on breaks, I'm a little more conservative than that.
well, to me, like, if it's a femur break, if the femur's broken, I wanna know what happened.
Yeah.
Because that's,
I want to know that they've also checked you out and know that it's healed
Yeah.
before I do anything.
okay. So we are moving on to structural correction of the proximal posterior tibia.
We had some of those.
Okay.
We sure did.
Okay, so proximal, what does proximal mean again? Closest to you. So in this aspect, the proximal posterior tibia, proximal will be up at the top. Okay, so this is our proximal end. As Lee discussed earlier, this is our distal end. So client is supine. No, they're not. Client, yes, they are.
Yeah.
Yes, they can. Client is supine. They are on their back. Therapist, that's what I'm looking at. Therapist is on our client's side. We have our rolled towel for stability. This is going to go under the proximal tibia, so underneath the top. We're making sure the leg is in alignment, meaning that it's nice and straight, right? We don't want it rolled in, we don't want it rolled out. Sometimes when you put somebody on their back, I see a lot with men, first thing their legs just roll out. Sometimes you'll just see like a foot roll in. So you want to make sure that that leg is nice, neutral, in alignment. And especially in alignment with the femur, right? We want to make sure that, again, that it's not just turned over here, that everything is nice, straight. Slow, steady compression on the distal end of the femur until the femur and the tibia are aligned. All right. So here's my femur. Okay, that can fit right in between there. That's a good little spot. I like that. Slow, steady compression on the distal end of the femur. So we have a proximal posterior tibia. That means that this tibia is down here. Okay, so it's gone posteriorly. Does everybody see that? Okay, how do you think we can get these two even? Because our ultimate goal is to bring them into alignment, correct? Bring them to straight. So if we have posterior, what do you think we would be doing?
That's how it goes in the bottom of the tibia and the tibia.
Okay,
You push down to fibula and let the what?
Femur.
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 You push down on the
okay?
femur.
Because as you're pushing, it's easier to push than it is to pull, okay? You wanna work with gravity. So as you're pushing slowly, that steady compression, that's what's going to help get in and with alignment with the tibia and the fibula.
The femur, yeah.
Make sense? Okay.
So I have a question.
Yes, ma'am.
So while you're doing that, are you holding the foot?
No.
No,
Okay.
so you're just hand over hand.
Okay.
So that your towel is gonna give you that stability
Okay.
underneath, and then your hand over hand is just doing that slow compression to help even that out.
Okay, thank you.
And what Micah said is if they're externally rotated and you're hand over hand, you are rotating them into alignment, holding them there while you're doing that direct compression down. You see that? So if somebody's this way, internally rotated or externally, like she said, you have to hold that alignment. So I'm either gonna push them over and hold them there like this, or rotate them externally and take them directly down. Okay?
On here it says contraindications are knee replacements, but I have a client that had the head of the tibia replaced.
Well,
What is that?
We'll talk about that, okay? We'll talk about
That's
that.
an interesting one.
Yeah.
I know.
Yeah.
Okay.
Yeah, no, we'll talk about it. It's different, but we'll talk about it.
Yes.
Will you have a case where it would be like, there's 4 different options here for the test, right? It's, you're either gonna have a posterior lesion
An anterior lesion.
or an anterior lesion in the femur, or you're gonna have a posterior lesion or an anterior lesion in the tibia.
Correct.
So whatever of those 4 options is, you're picking one, and then you're doing the appropriate treatment for it?
Well, today, yeah, correct.
Yes.
Today we're gonna be testing all of it. We're pretending on the people, pretending on your partner who doesn't have it. You're still gonna pretend to do the action.
Because here's also the thing is that you're actually gonna test them all, and whatever your person has, you're gonna correct it, okay? Maybe you shouldn't take too long to test, it shouldn't. But the other thing is that, and this is one of the dilemmas, is that, so we had some of those posterior proximal tibias. Is the tibia posterior or is the femur anterior? This test is gonna tell you, because it's gonna be the one that's not gonna move. Do you see what I'm saying? So I have this situation. I have a tibia that's posterior. I have a femur that's anterior. Who's the issue? We all looked and thought it was all the tibias out there, didn't we? We went, oh, look, there's a posterior tibia. But is it an anterior femur or is it a posterior tibia? This test is gonna tell you that, because it may look the same. You know what I mean? They have a short leg and a long leg. Is the short leg the issue or the long leg the issue? So this is what's happening, is Mike is giving you these different testings, which is gonna tell you which one it is, because no movement or very little movement tells you there's the issue. Movement is now your best friend. Movement, something not moving tells you you have an issue, okay?
And if somebody's leg, if you have them on the table and they're nice and even and everything rebound, some people might not have an issue.
Yeah, so pretend, that's when you're pretending.
Yeah.
That's when you're pretending, okay?
So,
Sorry, Mike,
No, no,
I get all
sorry.
passionate about things.
I love it.
So when you compress into, so when we're doing this compression, right, and this compaction going into the femur or the tibia, I'm sure you're wondering, what am I feeling for, right? How long do I hold? What do I do? So it really is, you're wanting to compress down until where you feel that it almost like fits. It's like you're stacking that parameter. So as I'm pressing down and holding it, it's like, I mean, if you feel like you can keep going, but I want to sit there until like I feel like that I've got that hard spot underneath me, right? And I've got that not necessarily the hard spot, but I've got the femur underneath me, and I'm compacting and I'm pressing and I'm just holding until I feel a release, or until it feels like that it just seated itself back in there. Because again, we're trying to get those level, and so as I'm compressing, compact, all of a sudden it might just go phew, and just drop down, or you just feel that little shift. That's when you know you've hit that spot. You've got your sweet
Slowly,
Slowly.
you are slowly putting this down there,
spot. Like a fine
Slowly.
diamond compression.
slowly,
Fine time.
okay?
Yeah.
So you don't wanna
Slow
take
and
it
steady.
into hyperextension or anything.
Right.
I think I have that big and bold and starred back some here.
Somewhere that says
Somewhere,
that.
yes.
Exactly.
Again, if your person does not have this, just pretend, okay?
Yeah.
Just pretend that, just pretend.
Because then
Just
somebody in
pretend.
your practice is gonna.
Yes. If you have somebody in here who's had a knee surgery or has a contraindication, if they have the other leg, that is, then try do the other leg. If somebody in here has had both things done, we have TAs.
Yeah.
Table.
Yeah. This treatment plan is not in your bodies.
That's exactly.
That's it. Yeah. Okay, we have just taken care of the proximal tibia, right? We're at the top.
Posterior?
Proximal posterior tibia. We're on the structural correction of the proximal anterior tibia. So these two tests, these two techniques we're doing is just hitting the top of the tibia. We're hitting the top, the proximal, the top part. Okay, so now in this one, our tibia is now more forward. I say forward, it looks up, but I mean if we're down here, right? The tibia is now more forward. Or it doesn't, so that's the thing. It doesn't matter what direction, it's still gonna be anterior, posterior. Whether I'm standing up, this is still anterior, this is still superior, this is still ascending, descending. If I'm flat on my back, it's still the same thing. This is still superior, it's still, it's all still the same. You're just in, your body's in a different position. So now we've got femur up here. No, we don't. We have
No.
tibia up here. So our stability towel is going to be underneath the femur. We are hand over hand under the condyles of the femur. Hand over hand on the tibial tuberosity. We want to make sure, again, that we're not pressing on the fibular head. Okay, so hand over hand, and we're doing that slow, steady compression down, very slow. There it is in my note, very slow. And we're doing that steady compression on the tibia because that's what's high, right? To bring that to neutral. Does that make sense?
Yeah.
Perfect. Okay, contraindications are the same. Things with knees, fractures, instability, inflammation. Inflammation, because we don't know where the inflammation is coming from. It could be coming from, it could be congestive, it could be like a, what's the word I'm looking for? A systemic thing. Could be within the body, it could be because there's an injury, it could be a hip thing, it could be a pelvic floor, it could be some different things. And now we're going to go on to the bottom of the tibia. We're going to do structural correction of the distal posterior tibia and structural correction of the distal anterior tibia. So we've all done proximal. So our towel was going underneath the femur and underneath the proximal end of the tibia. Now we're moving to the distal. So we're going to be putting a towel underneath our calcaneus, underneath the heel, and then underneath the malleoli, our lower joint line.
So what test was done for this one, treatment?
So the first test that I talked about was kind of doing those rebounds.
Right.
Those are the tests. These 4 are the treatments.
Okay, so in what?
So you can test it there and also when there's the dorsal.
We're going through it.
Okay.
Yes, we're going through it. All right, so with, oh, I can't see that.
Here, somebody at this table.
All right. So we have one hand on the distal tibia. Distal tibia, that is going to be our stabilizing hand. So you can see the hand that she has that's wrapped. That is our stabilizing hand. Our other hand is going to be on the base of the foot. That's our working hand. This is our working hand here. Again, close to the joint line. We are going to dorsiflex their foot, right? Dorsiflex to bring that into neutral. So if they are too far plantar flexed or if they're inverted evert, we're just bringing them to neutral into dorsiflexion. So you can see where Lee has her hand wrapped underneath. She's brought that up into that position. Dorsiflexion. So you're taking the calcaneus and the talus posteriorly. We're taking it towards the table. So with this one, if we have the distal end, distal posterior tibia, So that means that this tibia is dropped down, okay? So I have my foot, I have the tibia, so it's dropped down. So if they're standing, you might have seen that this lower part was posterior, was pushed back. So it might have looked like that, maybe the femur was too far forward, or this was shifted, or that whole leg was shifted back, but it's this down.
I guess my question is, does it relate, which of these tests on this page does it relate to? Is this just talking about the, I thought it was talking about the proximal.
So we are, we just went it all, and we're gonna demo it. So yeah, this will be your test, our rebound test that we're gonna do, and then these are gonna be our treatment pages.
So, but
So which
but
one
what
is
you're
this
saying is that,
related
so when you did that first testing too of the passive dorsiflexion of the foot there, that maybe gave you a little indication, but also, when you go down there, just, there's not a specific test on that page
Oh,
right there
you
that
can do-
talks about the distal
You can
end of
do a
it.
little rebound, my apologies, I have that there. You can do, same thing, you can put, you don't want it underneath the calcaneus, we'll put our towel underneath, kind of underneath that distal end, right? And you can still do a rebound. You can kind of put your hand on there and kind of
To
press.
see if the
Yeah,
see
yes.
it moves. Okay.
Not there, but yes, see if there's any sort of movement in that. So you'll do that with the up top, you'll do the same thing down below, correct?
Okay, I'll put my 2 cents in now. Okay, so I've got my foot, and I've got my tib and fib. You guys being behind me, it's a problem.
Come up here.
And come up here. Oh, yeah, that's right. I was so happy in my corner. Don't leave me, don't leave me. So I've got the foot, and I've got the tib and fib, okay? All right? So one of the things is that your tib and fib should be enough in front of the back of your heel here, okay? So that I should feel it sort of not be into the forefoot. This is something you're just going to have to learn to assess based upon holding a lot of people's feet and legs. So we definitely have with Andrea, because of her, I don't know if it's just because of her sprain, but she has definitely got both the tib and the fib anterior, okay? So it's too far forward towards the front of the forefoot. It's too far forward towards the front of the forefoot. And then you can see it, and you can actually see it or feel it, that it's too far back on the calcaneus. Is that you will learn to sort of assess that. So we'll go around feeling where it is, because I actually don't do this as a rebound. I do this as a, like, here I put the foot into dorsiflexion, because you want to have the foot in neutral, like Micah said. You need the foot in neutral, so you hold the foot in neutral, then you put your hands, you know, I had to go around and tell everybody, take everything out of your hands, because you're just feeling it, into dorsiflexion, and I'm holding this, and if I'm too far up, then I'm anterior, and if I'm too far down, then I'm posterior. And then she's going to tell you how you're going to correct that. But it is something that you actually do because you're feeling position. It's positional as opposed to rebound up as a test, okay? That was a lot of words to say, it's positional, okay?
And it's part of what you did when you did that passive.
Well, when you dorsiflex, because no, we can't say that, Julian.
No, okay.
Because part of the reason you can't, and sometimes when you dorsiflex, when the tibia is too anterior, it'll stop you. Okay? True. But you can also have the talus be too anterior and stop you. So you have to assess. I put the foot somewhere. Grab the foot, Micah. Just lift it right off of that thing. Oh, yeah. Is that so? When I go to dorsiflex, I can have 2 reasons why I can't dorsiflex. One is because my tibia is too anterior and it stops me. And one is because my talus is too anterior and it stops me. So you have to make the assessment of which one it is by you know, and as soon as you put your hands on those malleoli like this, as soon as I put my hands on the malleoli and I'm getting ready to dorsiflex, I already know right then, that's when you're starting to learn to teach yourself to go, oh, it's anterior. Look at how far up I am. Look at how far up that is. And then you dorsiflex and it'll stop you right away. Okay? All right? All right. Go ahead, Micah. Sorry.
No,
There you go.
Okay. All right, so if we have that distal end that's posterior. Our towel is going to be underneath there. So our action on this, we're actually going to be taking our hand. We're going to be holding on. So it's bone of the foot. This big thing here, your heel, this is your calcaneus. Okay? Big word for your heel. Calcaneus. Then your talus is right there. So she's holding, we've got the calcaneus in our hand. Nice little grip, just kind of how you had before. You might want to, some people might be the four. I find it easier, just the calcaneus. And so you're taking that posteriorly. So as our towel is underneath here, right, and our hand is stabilized, we are taking the foot and we are dropping it down towards the table. Foot and the talus, stabilizing, again, light pressure, taking this, and we're just dropping the foot towards the table. When we take the foot towards the table, then that is going, so we have a high posterior tibia, or
Posterior distal.
Thank you. And so as you drop it down, as you drop the foot down, well, I can't really do that, is there? It'll level it out. Flip onto the back page. Distal anterior tibia. Are these numbered on here?
Yeah, page 10.
Is it? Okay.
Yeah.
Not on all the pages.
Oh yeah, not on the new one. Okay, that's what I was looking at.
Oh, on the 3 different individual ones that I did? Sorry, y'all.
All right.
And it's going to be different on those.
This is the structural.
Okay.
Yep. Distal
Distal
anterior
anterior
tibia.
tibia. All right, so again, we have our towel rolled under the calcaneus, not under the tibia, underneath the calcaneus. Now again, with the calcaneus, calcaneus is a big bone. We want to have the foot in neutral, so it's going to be resting, factor here. We don't want it resting underneath here, so if their foot is a little bit more plantar flexed, we want to bring them into a neutral position, have that towel underneath their calcaneus. We're going to have one hand on the anterior tibia and the other hand on the plantar surface. Nope, never mind.
Hand over.
We're going to have hand over hand on the distal end of the tibia. I pulled in, I didn't have that printed, so I pulled an old one. All right, make sure our foot is aligned in dorsiflexion, and then we are putting sustained pressure directly down on that distal end of the tibia until we feel that there's an alignment. So the first one we're doing, towel underneath the tibia. We're taking the calcaneus towards the table. That's to bring that level. And this one, we are putting the towel under the calcaneus and we're dropping the tibia to meet it.
Yes. This is probably something I should have learned last time, but when you get the alignment, do you hold it there to let the body settle into it, or do you find that alignment, it dropped in, and then just jump off?
So when it's going to be that slow compression to get there, and you